So we have three papers today. And the first one is on the impact of exposure to IT in determining women's knowledge of complication during pregnancy, labor, and postpartum. This paper is prepared by Erna Nurmawati from Politeknik Statistika STIS, Joseph Gabriel Napitupulu, also from Politeknik Statistika STIS, and Teguh Sugiyarto from BPS Statistics Indonesia. The second paper is a paper by Dian Kristiani Irawaty from BKKBN, Introduction of Moringa oleifera as Plant Food Supplements for Breastfeeding Mothers, a rapid review. And the last paper is on the effects of birth spacing on stunting in Indonesia by Sofia Afkarina Mumtaza from UGM and her colleague Evi Nur Afifah, also from UGM. I'm really excited and happy to see the titles and the affiliations because these are the topics that fall within my research interests and also have close affiliation with my beloved colleagues in BPS Statistics Indonesia, BKKBN, and of course UGM. So it's such a pleasure to be able to chair the session today. So without further ado, I'm going to offer the floor to the first presenter. Will it be Pak Teguh? Will you be presenting the paper on behalf of your colleagues?
Yes, true, because of my colleague have some obstacle to present today, so I will represent them.
Okay, great, perfect. So we have about Ibu Ratri, am I correct? We have about 20 minutes, is that right? For each presenter?
Yes, Bu Ariana.
Yeah, so about 15-20 minutes, and I'll pass it on to Pak Teguh. And I think what we'll do, because the papers are so nicely nicely linked to one another, maybe what we'll do is we'll listen to all three presenters, and then I will do the Q&A right at the end, because I think the papers are speaking nicely to us, to one another. Ya, silahkan, kami persilakan.
Okay, wait. I will share the screen first. Can you see the screen that I have shared now? Okay, thank you very much for this opportunity.
Yeah, sorry, Pak Teguh, maybe what you could do is turn on the slideshow. So just click on the slideshow view. Fantastic, thank you.
Okay, very nice introduction from Ibu Ariana. To be honest, I'm here as the third writer, and I only assist them a little, assistant. And sorry, I will introduce myself a bit, just a bit, that study and population studies several years ago, but today I have a different duty because my focus is on economical statistics. My team produce inflation and such as indicator in economic aspect. So if there are so many mistakes or weaknesses from this paper, you can give us some constructive input to develop later. Okay, I will start today with the general outline. During approximately 15 to 20 minutes, I will discuss some fine points, including introduction. In here, the problem and objective are revealed. Then the data source and methodology will be described in brief, followed by the main part of discussion that explain some finding of data analysis. In the last part, some point of conclusion and recommendation will be delivered. I believe that most of us understand that maternal mortality ratio is still one main problem of maternal health in Indonesia. Back to Millennium Development Goal, reducing maternal mortality ratio belong to one of unachieved target. An estimation based on Indonesian Demographic Survey 2012, the speak that maternal mortality ratio in Indonesia is 359 per 100,000 live birth. The condition did not much change after that, which is indicating from 2015 International Population Census, the figures drag Indonesia in group of countries with high maternal mortality ratio in ASEAN. Again, we can see from this graph shown the trend of maternal mortality in Indonesia from 1980 to current condition. The decreasing trend is seem get opposite direction started in 2007 based on the result of Indonesian Demographic Health Survey. However, this indication may not be true since the nature of maternal mortality is rare cases and may produce estimation which contain some sampling bias. Because of the bias, it is possible that standard error quite high. Then the interval estimation of maternal mortality ratio becomes so wide. For example, we can see in the little graph there in 2007, the point estimation is 228. But considering the high standard error of the estimation, the MMR or maternal mortality ratio may be true in the range of 148 to 370. So if the maternal mortality ratio estimation in 2012 is 359, it is also possible that maternal mortality ratio in 2007 and 2012 remains stable. It can be seen from the intersection of interval estimation between two different years. We can see in the little graph there are so wide intersection between interval estimation of maternal mortality ratio between 2007 and 2012. Therefore, it is difficult to say that the maternal mortality ratio gets downward or upward trend, but absolutely it's clear that Indonesian maternal mortality ratio is still high, and this is such a big problem there. Then we also know that government had delivered many health programs to tackle the maternal health problem and improve maternal health, such as provision of health facility, improvement of health quality, distribution of health personnel across geographic area, or many health intervention to assure that women get adequate treatment, such as husband alert and etc. However, those interventions do not sufficiently reduce the maternal mortality ratio at expected level. Based on this condition, this paper focused on the different aspects to enhance maternal health. The supply side, like provision health facility, quality improvement, have become government concern. Then adequate attention must be also provided in the demand side of maternal health program. Therefore, this paper aimed to assess the woman's knowledge on maternal health and some aspects which influence the woman's knowledge. By understanding the subject, it is hoped to increase the demand of maternal care and utilization of health services. In addition, since maternal mortality often happens on critical time, such knowledge on maternal health will be very crucial to prevent the health problem getting worse because of the delay to obtain adequate care. The idea is up to there also based on the comprehension of theory planned behavior. The theory maintained that three core components, namely attitude, subjective norm, and perceived behavior control. Together, these three core components shape an individual behavior intention. In turn, behavior intention is the most proximal determinant of human social behavior. In this sense, the provision of knowledge can be a prerequisite of action, or knowledge may be transferred into action through its influence to determine the attitude, subjective norm, or perceived behavior control. However, we also realize that many research reveal that knowledge does not always have correlation with the behavior. For these cases, it may be that the knowledge does not sufficiently shape the people perception on the positive aspect of doing an action or particular behavior. And these are the independent variable that we use during the data analysis. The dependent variable is know the danger sign of maternal health during pregnancy, labor, and postpartum. Well, the independent variable, you can see here, there are 9 independent variables. All of the data come from the Indonesian Demographic Survey 2017. And this is the analysis process to develop the statistical method. We use logistic regression, binary logistic regression, because the dependent variable we group into 2 different categories. And there are some important points in the descriptive analysis that almost 60% of women know at least one danger sign of complication during pregnancy or labor or postpartum or postnatal. Sorry, why it is not move? Sorry. Okay. And then approximately 50% of women know about danger signs during pregnancy and labor in rural and urban area, and there is no much differences between 2 different areas. But if we differentiate between the stage during the labor, pregnancy, or postnatal, we can see here that women have the least knowledge during the postnatal. And this figure need attention since women knowledge is one predisposing factor to seek health services, especially during the postnatal. Sorry, next. And this is the statistical model, and I will not explain in detail because it's quite complicated to explain it. But in here we can see that the assumption to build the adequate or good fit model had been fulfilled. So we can see the G test result comply with the adequate or good fitness of the model. And this is all of the statistical tests for individual variable. We can see here within a significant of 5%, there is a sufficient evidence to prove that women education attainment, frequency of reading newspaper, frequency of watching television, woman ownership of television, mobile phone, and radio has an effect on woman knowledge of dangerous signs during pregnancy, labor, and also postnatal. And this is some example for the interpretation of the result logistic regression. I give you some example. For example, for the owning the television, women who watch television more than once a week have a tendency of knowing about dangerous signs during pregnancy with an opportunity of 1.538 time greater than the woman who hadn't frequently watched TV. So in here, accessing the television have a positive impact for increasing the woman knowledge of maternal health. It also happened for the education attainment, reading newspaper, having telephone, mobile phone, and also listening the radio. However, something interesting come up from this research that respondents who access internet tend to have lower knowledge on maternal health. This is quite difficult to interpret. And then we again assess based on the data source. We refine the analysis by using interaction of different variable. We find some literature that accessing internet not always or not have a sole influence on the knowledge of individual knowledge, but when it combined with the educational level, it will have a positive impact of the knowledge, because the educational level or education attainment act as a screening to read which is important or which is not of the internet content. So after combining the interaction between education and in the access of internet, we can find that a variable interaction between education and frequency of using internet reveal that combination of the higher education and using internet every day tend to have higher knowledge on maternal health. However, this result did not consistent across different category, because in some category, even though they have a lower level education, they also more knowledgeable of maternal health knowledge. But in the second point, the variable interaction of education and access internet depict a consistent result that respondents with higher education and access internet in the last 12 months have higher knowledge on maternal health. So based on this refined analysis, we can make a simple conclusion that actually accessing internet still have a positive impact for increasing the woman knowledge on maternal health. Then this is some comparison from the other study from some literature that it may be true, it can be true that accessing internet not always have a significant correlation with the knowledge, because in some population group, they have different language or common language with the content of internet. And maybe we also know that in Indonesia, accessing internet not always the same as accessing knowledge, because we use the internet for reading something else. Maybe we know that we used to read WhatsApp, something like that, rather than accessing useful knowledge or useful science, something that good for us to improve our professionals, something like that. So in here also there is some literature that more educated people use the internet more effectively for information need, whereas the less educated seem to be interested for entertainment function of the internet. Based on this data analysis, we can conclude that women education attainment, frequency of reading newspaper, frequency of watching television, woman ownership of television, mobile phone, and radio has association with the woman knowledge of dangerous sign, but the opposite for accessing internet. This result reveals the effective of internet to influence women knowledge and maternal health must be improved, because its potential in the digitalized era and the progressive trend of internet penetration in Indonesia. And we make a recommendation that the government has to utilize the availability of advanced information technology. Unfortunately, this study indicates the assessing interest not in line with obtaining knowledge on maternal health. This might mean that the potential resource of advanced technology information is still underutilized. I think that's all of my presentation. Thank you for the attention.
Terima kasih. I encourage the audience to use their reactions if they can do that. So my reaction is that, yeah, that was super good. And you already, you finished ahead of time. So that will leave a lot of time for us to kind of follow back, follow up with the question and answer, the questions from and comments to your paper in the Q&A session. So for the audience in the room, I encourage you to take notes if you have any question for Pak Teguh and colleagues for their paper. And I will give the opportunity next to Ibu atau Mbak Dian Kristiani Irawaty from BKKBN to present her paper on the impact of Moringa oleifera. I had to Google what that was before sharing today. It's daun kelor, ya, Mbak Dian, is that right? Okay, so I think you're still muted. And once you have pressed slideshow on your slide, we look forward to listen to your study. Terima kasih.
Thank you, Ibu Arin Utomo. Assalamualaikum warahmatullahi wabarakatuh. Today I would like to present my research about introduction of Moringa oleifera. Wait, slideshow. Moringa oleifera as plant food for supplement for breastfeeding mothers. Rapid review. So the background of the study is the World Health Organization has recommended that the baby should be breastfed within the first hour of life and exclusively for the first 6 months of life. And in Indonesia, 96 of children less than 24 months are breastfed. However, only 42% of the children are exclusively breastfed. So as per World Health Organization recommendation, it is recommended for 6 months exclusively breastfeed. As a result, not breastfeed according for recommendation, Indonesia is estimated to contribute to 5,377 preventable infant deaths due to diarrhea each year. For those women who are unsuccessfully breastfeed their babies believe that they produce insufficient breast milk, which lead them to wean their babies before the recommended age of 6 months. To augment breast milk production, a substantial number of women in Asia and Africa has turned to drink and consume herbal galactoques like Moringa oleifera. Moringa oleifera in Indonesia are known as kelor. Kelor is unpopular among Indonesian people to be consumed due to its expelled spirit myth. So if you get something bad or something like spirit coming to your house, or somebody is in critical condition and they have critical in several months and they're not dead, so the kelor is given to the critical person. Kelor. Yes. So most people are not eating kelor in Indonesia. Existing information regarding Moringa oleifera as plant food supplement for particularly increasing breast milk production for mother is still rare. So this study aimed to conduct a rapid review on the effect of Moringa oleifera consumption on breastfeeding mother. So because of the pandemic, I only can conduct a rapid literature search in database, including searching from PubMed, Google Scholar, Medline, and Base Web of Science and Concrete Library. The articles were searched during January to March 2021. The keyword is Moringa oleifera or drumstick tree or horse radish tree or shifera or bean olive tree and breastfeeding mothers or milk. Only English and Bahasa language paper were included. All studies included original data, case report, case series, descriptive observational studies, and randomized control trials. So this is the result. The record identified through database search and gray literature are totally 1,415 papers. However, I found 648 duplicate papers, so I removed it. After that, the record were screened, the abstract were screened, and there were 767 paper. However, because from the abstract and the title is not included the breast milk. and the Moringa oleifera. So I exclude 518 papers. And after that, full text article were assessed for eligibility for 249 paper. Full text article excluded because lack of information of Moringa and breast milk. So the studies included in the review total is only 6 paper. So the result is from Fung Taman and Pupong, they conduct a double-blind randomized controlled trial. The interesting finding from their study is the average volume breast milk was increasing in 3 days postpartum. The consume of Moringa oleifera capsule led to 30% increase in the volume of the breast milk. Moringa oleifera leaf increased breast milk volume by increasing prolactin and providing essential nutrition like protein, zinc, and vitamin B, and it takes about 24 hours after injection for the Moringa oleifera to work. And Sajid and friends also conduct research about natural sorbet by giving the seed of Moringa oleifera to fine powder. The powder was passed through 75 millisieve and was washed into deodorant water for several times. So after the mother who consumed the Moringa oleifera flour, it is those mother they produce increasing breast milk in average of 5 milk by consuming 30 milligram of Moringa oleifera powder. And Sumarni, this research is conducted in Lampung. They conducted a pre and post control group design. So they consume 50 grams of Moringa cookies for a month. So after that, it showed that the consumption of Moringa cookies increased the quality of breast milk, especially the protein level compared to the non-consume of Moringa cookies. Raguindin and their friend conduct research by giving Moringa oleifera as their consumption for breast milk mothers. So the pooling of study revealed a significant mean increasing in milk volume on day 7 among mothers who received Moringa. Patients of the Moringa group have high level with significant milk of increasing breast milk 19 milligram. Suhartati, it is also conducted in Indonesia. The sample is 40 pregnant women. Saliva sample from nursing mother. Moringa flour, they were given Moringa flour provided by the same benefits. So the breast milk contain more Fe. Fe is like zinc, Fe against cortisol level during pregnancy, but not significant at the lactation. The Estrella, the sixth research is about Estrella and their friend. They conduct double-blind randomized control trial. The Moringa oleifera leaf increased the volume of breast milk produced by mother of preterm infant on postpartum in day 3 to 5. So Moringa oleifera leaf increased breast milk volume by increasing prolactin and providing essential nutrition. Moringa oleifera leaf contain protein, mineral, vitamin, fatty acid, and phytochemical that lead to high quality of breast milk. It takes about 24 hours after injection or consumption for the Moringa oleifera to work. No adverse effects were reported in those 6 human studies. So the conclusion is Moringa oleifera is a herbal galactose that has been used to increase the volume of breast milk. The Moringa oleifera contain many essential nutrition. Moringa oleifera is recommended to be consumed by breast milk mother as one of the local food. It is cheap, but high nutrition, and it is very promising to increase the volume of breast milk among postpartum mothers. The study recommended Moringa oleifera routine consumption about among breastfeed mothers to ensure adequate supply of breast milk to ensure breastfeeding for 2 years of the babies. Thank you. And this is the reference.
Terima kasih sekali, Mbak Dian. It's so interesting. I'm taking notes and yeah, I just remembered when I was pregnant, when I had babies I had my first son in Indonesia. I didn't know anything about Moringa, but I had the daun katuk pill instead. So very, very interesting. So so folks, those of you in the room, if you have any question for Ibu Dian, please write them down in your notes and we'll get to them soon after the last presentation by Mbak Sophia from UGM, whose paper is on effects of birth spacing on stunting in Indonesia. This is a paper written by Sophia and also her colleague Ibu Evi Nur Afifah, also from UGM. Silakan. I think you are still mute, Ibu Sophia. Mbak Sophia.
Yeah, I'm sorry. I'm still waiting for my PPT to load. It looks take a bit longer time.
That's okay. Take your time. While we're waiting for your PowerPoint to load up, I would like to say hello to some familiar names in the audience. I could see Mbak Maria Gayatri from BKKBN, right? And Pak Salut. Hi everybody. Who else do I know? Oh, Mbak Susi Sarumpait. I wonder whether Mbak Susi from ANU. Yeah, good to see your name. We look forward for a great discussion, lively discussion at the Q&A. How are we going, Sophia? Are you able to share the PowerPoint yet? Looking good. Great, it works really well. I'm going to mute myself and over to you. Thank you.
Okay. Good morning, honorable ladies and gentlemen. I'm Sofia Mumtaza. I'm from Economics, Universitas Gadjah Mada. Today, I'd like to discuss the effect of birth spacing on stunting in Indonesia. This presentation will be divided into 3 main parts. There are background, data and methodology, and finally the result. First, we will begin with discussing the background of the study. Stunting is the impaired child growth due to poor nutrition, repeated infection, and inadequate psychosocial stimulation based on WHO 2015. Children are defined as stunted if their H4H score is more than 2 standard deviation below the WHO child growth standard median. Stunting not only causes children impaired physical growth, but also inhibit the development of children's brain, which its impact could last longer. For example, stunting has been shown to reduce a child's IQ by 0.6 standard deviation, which means that the child may be at a serious risk of impaired brain development. Furthermore, it will affect children's cognitive abilities, language, and motor sensors. This fact has implication for poor performances during formal education process, low productivity, and also low productivity levels. And therefore, in long term, these factors can reduce the quality of workforce in adulthood and affect the income received. In the economy as a whole, Galasso and Wagstaff at 2017 calculate the costs that occur from not reducing stunting rates in the past. As a result, the average cost of stunting between countries is 7% reduction in GDP per capita. Specifically, for the calculation for Indonesia shows that the cost of stunting is a reduction in GDP per capita at 10.5%. Galasso and Wagstaff at 2018. Based on riset kesehatan dasar or Riskesdas, stunting prevalence in Indonesia in 2019 was 27.6%. This is actually a decrease from the previous stunting prevalence in 2018, which was 30.8%. However, the stunting prevalence in Indonesia is still high or above WHO's limit, and this number exceeds the average stunting prevalence in Southeast Asia. Stunting is caused by various factors that vary in each country. In Indonesia, there are several important factors cause stunting. First, poor parenting practices such as low nutritional fulfillment during and after pregnancy, also low rate of breastfeeding. Second is limited health service, especially for mother. And the third one is another lack of access for household in nutritious food, clean water, and also sanitation. But there are actually other important factors that affect stunting from mother's side, including mother's height, teenage pregnancy, conceiving at an older age, and short birth spacing. These factors can interfere with the availability of nutrients of the fetus because they have to compete with the mother's nutritional needs. In overcoming malnutrition, various interventions with faster mechanisms such as promoting education about health and nutrition, supplementation and fortification have been widely analyzed and applied. Indonesian government also has implemented this effort, but there are also important mechanisms, although classified as a longer path, but also need to be considered. This factor including increasing economic growth, increasing education for women or mothers, and longer birth spacing. And one factor that may cause malnutrition in children but has received a little attention is birth spacing on the time that elapsed between successive births of children based on Kribel, Murray, and Minotti at 2009. Now let's take a look on birth spacing data in Indonesia. The percentage of ideal birth spacing in Indonesia tends to decline in recent years, except from 2002 and 2007. But for example, calculation in 2017 show that percentage of ideal birth spacing in Indonesia is 24%. This indicates a decrease of 1.1 percentage point from previous year, which is 2012. While many previous studies found that ideal birth spacing associated with better child health outcome, for example, Kara and Miller at 2020 found that children who are less than 24 months spaced with their siblings are 23% more likely to be stunted than children who are 2 to 3 years spaced with their older siblings. Furthermore, other empirical evidence shows that short birth spacing may predispose stunting probability because the non-optimal intake of mother's milk. Short birth spacing can cause overlap breastfeeding, for example, or the condition when the mother is pregnant while still breastfeeding her previous childbirth, by Marquis et al. At 2002. Numerous empirical studies have shown the evidence that birth spacing can affect children's health through various potential mechanisms. First, maternal depletion or decrease in nutritional status of the mother, which the mother has not fully recovered from previous pregnancy to support the next pregnancy. Second, competition between siblings, particularly in obtaining breast milk. And the next is decrease in investment resource owned and provided by parents. For example, based on Kara and Miller at 2020, children with long birth spacing receive more prenatal care, such as regular prenatal checkups and tetanus shots. And finally, disease transmission between close siblings. That is occur when older children reach the age when contracting infectious disease is a common. that is around the age of 2. And at the same time, the younger sibling who are still infants are prone to the contagious disease and can severe more due to low immunity. And next, we will discuss about the data and methodology. This study using IFLS data or Indonesia Family Life Survey in wave 4 and 5, and also use the panel data in wave 3, 4, and 5 IFLS. For the main sample in this study, use children age 1 to 5 years, and for the panel data, the sample was children age 1 to 5 years, 7 to 12 years, and 14 to 19 years. And here's the methodology used in this study. The probit model replicated from Kara and Miller at 2020 with stunting as the dependent variable and space as the interest variable. And this study also control for the child characteristic variable, mother characteristic variable, and also household characteristic variable. Beside probit estimation, the study also used 2SLS estimation to overcome the endogeneity problem. The first model is 2SLS model at the first stage with modern contraceptive use as the instrumental variable, and the second model is the structural model. And finally, the result.
Are you okay, Sophia?
Yeah, I think my presentation. Yeah.
Is it frozen?
Yeah, it is not responding in here.
Oh, okay.
Sorry.
That's all right. Oh, we have plenty of time. Do you think you could open it and send it to me? I could share your presentation from my end if you don't mind. Can you access it?
Yeah, I can access it.
I'll send you my email. Where is my email? I'm sorry, everybody. So for the audience in the room, this is a good chance for you to grab a cup of tea. Minum teh sebentar sambil nunggu. Okay, can you see my email? Maybe you could send it to me and I could try screen sharing it. While we wait for Sophia, how about I ask people or the audience in the room, in the virtual room, to use the chat function and introduce yourself. Is that okay? We've got quite a lot of participants, around 20. So if you don't mind, while we wait for Sophia to return to the results of her very interesting analysis on the role of spacing on stunting. Yeah, please use the chat room. Maybe Mbak Ratri, you could start using the chat room to introduce yourself. Tell us a bit about you. And one fun fact, what's your hobby? What's your favorite food? Or what do you look forward the most? Do you think you could send it to my email? It's not recognizing it. It's not recognizing it on the chat, Sophia. I just sent you the, yeah, I just have that my email address just right at the top there.
Okay, I'll try to send by the email.
Thank you. Apologies everyone.
Saya saja, sekalian saya juga student assistant di sini.
Yeah, atau ke Mbak Ratri, anywhere is good. Just as long as we have a copy to share. Okay. Come on, everybody. Please introduce yourself in the chat. Chat away. We're trying our best to replace the in-person conference with a virtual conference, and so far it's been really great. I really enjoyed the virtual lunch that was hosted by the ANU Indonesia project yesterday. Although it wasn't lunch Melbourne time, it was around 4 o'clock, so afternoon tea for us. But hello, Mbak Susi. Oh, Mbak Maria, you've got a question for Ibu Dian. Maybe we could just maybe Ibu Dian, you could quickly answer that question while we wait for Sophia's presentation to arrive in our mailbox. Which Moringa oleifera product is best consumed by breast milk mom? Yeah, are there different kinds? Like, do I just like randomly plug a down calor and should I assume that it's safe?
Yes, actually, down calor is it's just, can I show it? It's just like this. It's very tiny. It's just like bayam. So the best consume for breast milk mother is the fresh one, But because the calor tree is not no, it's difficult to find it in Jakarta. So there are some company produce some variation of Moringa oleifera. Like for example, the coffee and the chocolate and the capsule and the cookies and the tea. For the breast milk mothers, if they like the coffee, they can drink it, or if they like the chocolate, I think everybody like chocolate and they can consume it. As long as the breast milk mother are happy, they will produce their breast milk more compared to unhappy mother like that. Thank you, Bu Maria. Thank you, Ibu Ririn.
That's so cool. So is it the leaf or is it the seed? Because I think in one of the paper that you showcase in your presentation, they had to grind the seed or something.
Actually, all the tree, the flower, the leaf and the seed can be consumed by breast milk mother, but most of the research are identified the leaf like that.
Okay. Oh, the leaf.
So,
okay.
But we can consume the tree the dried leaf like this. I consume it every day because it's good for our health like that, and it's cheap because I have the tree in my house. That's why I'm curious about the tree. And when I talk to my friend about the calor, they just like this. Calor is for spelling the hantu ghost like that. Just. And they do not want to consume it because they feel they scared about the tree. But in fact, in the reality that the kelor is well consumed in Hawaii, in India, in Bangladesh, and in some of India, they make curry for the kelor like that.
Oh, that's so interesting. How are we going, Sophia and Mbak Ratri? Are we able to share the presentation yet?
Kak Sophia hasn't contacted me yet, so
Okay.
I'm waiting for a response from Kak Sophia.
Okay. It's okay. Maybe I'll give another minute, but just to respond quickly to Mbak.
I'm sorry.
Yeah, that's okay. Just to respond quickly to Mbak Dia, I was just gonna say, it's so interesting because, I guess if we plant pohon daun kelor, we get two benefits, right? In one, not only it's good for your breast milk, but it's also good for ngusir setan. So yeah, definitely, I'm gonna start doing
Yes,
that.
yes.
Okay, Sophia, you know what? Don't worry about sharing the presentation. You've basically are you still here, Sophia? Can I see you?
Yeah. I
Yeah.
think it took a while to open the email as well.
Okay.
Maybe
Well,
can
that's
I
okay.
try to
What if you
to
just tell us your
share?
results? Yeah, what if you
Oh, yeah.
just tell us your results, turn on your camera, and don't worry about sharing a presentation. We'll just do it the old school way and listen to you. So you already showed us the lit review, you showed us the data and strategy of analysis. So maybe we'll just we look forward to hear your key findings. Maybe you could share that with us without sharing the PowerPoint. Let's do that.
Okay, thank you.
Sophia, are you here with us still?
Yeah.
Yes, we
I'm
can hear
sorry,
you.
my Zoom is
Yeah,
okay. I'm
that's
sorry,
okay.
I think it takes a while to open my camera, so I'm gonna tell my result first. Maybe the camera will show later.
That's okay. Yep, we're happy to listen to you. Please go ahead.
Okay, so the result is for my data in main sample, it is show that 15.5% of the primary sample was stunted, with the average of birth spacing was 55.46 months or 4.6 years, and 29.3% space less than 3 years, and 56.1% space 3 to 7 years, and also 14.7% space more than 7 years apart from an older siblings. While for the panel sample, 24.1% of the children stunted, with the average of
Can anyone hear Sophia, Ratri?
I cannot hear.
Oh, I think we've lost Sophia.
I think Kak Sophia still trying to overcome the technical difficulties.
Here we are. We'll just give
finally.
Yep. Okay, so you were saying that on average, the spacing is about 55.46 months. Please go ahead.
Okay, and the result of probit estimation show that birth spacing in month show a significant result with the probability of stunting, but its coefficient is relatively small. That is, and in every a year increase of birth spacing, the stunting probability of children will decrease at 0.009. And while for the categorical variable, the birth spacing less than 3 years shows a positive and significant result or significant association with prevalence of stunting. That is 0. That is, if a children born after an interval of fewer than 3 years, then the prevalence of stunting is 0.041 higher than those who are spaced 3 to 7 years from an older sibling, while being spaced more than 7 years from their older sibling show no significant result on stunting probability. And then in this study, the association between birth spacing and stunting probability also analyzed through the panel data collected from 3 waves of IFLS. This step was taken to document the association between birth spacing and stunting probability over children's growth. So the stunting probability of 1 to 5 years age group is 0.067 higher compared to the same age group, but spaced 3 to 7 years old from the older sibling. And this finding is in line with Kara and Miller at 2020, who state that birth spacing of less than 3 years has a significant and positive effect on children aged 1 to 5 years. Also, these effects become insignificant as the child ages. This is especially evident at the age of 12 years. But for the 7 to 12 years age group and 14 to 19 age group, the birth spacing, regardless 3 years, regardless of the group of birth spacing, show an insignificant impact to stunting probability.
Oh.
And then the birth spacing variable in this study has expected to have an indigeneity problems. This problem is a common issue when researchers try to estimate birth spacing. However, mass study on birth spacing and child health outcomes still do not control for indigeneity issues based on Moritoris at 2019. So based on Reasons-Week at 1986, said that the interval between birth of the second child and more are influenced by the endowment of children born earlier or older. So the birth spacing of second or more children is actually a positive function from the endowment of their older siblings. And that's why the endogeneity problem on birth spacing variable most likely biases the appropriate estimation result, and therefore an instrument variable was used along with 2SLS estimation in this study. The IV used is modern contraceptive usage, specifically the duration of modern contraceptive usage before the birth of children sampled in the study. For the final result of the SLS estimation results show that birth spacing of birth spacing in months show a statistically significant effect on stunting probability. There is in every 1 year increase in birth spacing will decrease stunting probability by 0.039. This result is in line with the result in probit estimation, but have larger magnitude in coefficient. While for the child characteristic, the age of child show a positive and significant association with stunting probability, that as child grow older, the probability of child suffering from stunting increases by 0.01, but the effect is the effect in the probability decrease with the age. Also, birth orders show a negative and significant association with stunting probability. There is younger child in the family, the younger child in the family, then the probability of suffering from stunting decreases by 0.02. While for mother characteristic, mother years of education show a negative and significant effect. That is, as the year of education of the mother increased in 1 year, the likelihood of children suffering from stunting decreases by 0.008. And for the household characteristic, sanitation variable, per capita expenditure, and urban variable shows a negative and significant result. First, for the sanitation variable, state that the probability of child suffering from stunting is 0.042 lower if they are a member of household with adequate sanitation facilities. And for the per capita expenditure, show that every 1% increase in per capita expenditure will reduce the stunting probability by 2.5%. And last, children who are a member of family living in urban area have 0.05 lower in stunting probability than children from family living in the village. While for birth spacing in categorical variable, space less than 3 years will increase stunting probability by 0.24 more than other birth spacing categories. This in line with Gribel, Murray, and Minotti at 2009, who state that birth spacing less than 3 years is directly related to stunting or one of the risk factor influencing the probability of stunting in children. While for
maybe if you have like the last 1 minute to wrap up your key finding.
Okay.
So what's the key? You've had all these really cool variables in your model. What's the bottom line of your analysis?
Okay, so from this study, we can conclude that short birth spacing has proven to aggravate the probability of child suffering from stunting. Specifically, birth spacing of less than 3 years can increase the stunting probability compared to birth spacing of 3 to 7 years. And the result of probability estimation against panel data show that the effect of birth spacing less than 3 years proven especially in 1 to 5 years age group. And the implication of this study is increasing birth spacing between 2 consecutive births as a stunting agenda in Indonesia. I think specifically is increasing birth spacing campaign popularity, so that campaign on health birth spacing for maternal and child health can be widespread to the Indonesian citizen and can be carried out simultaneously with the implementation of family planning policy in Indonesia. Yeah, I think that's all from me. Thank you.
Great, thank you so much. Thank you so much, Sophia. That's a very interesting paper, and you went through it. You persisted despite the technical glitches, and that's, I guess that's the time that we're living at right now. It's, Zoom after one Zoom after another. So yeah, thank you very much. So what I would like the audience to do now is to move on to the Q&A session. And if you would like, please use the raise hand function or use the chat box. And if you would like to, you could also open your camera so I could see who's who in the room. So hello, Mbak Susi, kawan mama from Canberra. It's so good to see you. I've got some questions here already in the chat box. So maybe instead of me reading out, Mbak Maria, we've already read your question. How about Mbak Sari? Mbak Sari, would you like to, hi Mbak Maria, Mbak Sari from BKKBN, would you like to directly ask your question to Pak Teguh. Silahkan.
Well, okay, thank you, Miss Arin. Nice to meet you. My question is written in the chat box to Pak Teguh. Pak Teguh, as one of the government and also dealing with maternal health, from your result, can you tell us about what are the best information to deliver, and what are the best media to choose for disseminating and socializing the information? Which media from your study is the best for delivering the information for increasing maternal health?
That's a great question. Policy implementation from BKKBN. So yeah, this is your chance, Pak Teguh. What should BKKBN do? Maybe infographics through WhatsApp or lambe turah, maybe it's even better.
That's possible because nowadays everybody is with lambe turah. Right?
Silahkan Pak Teguh.
Okay, baik. Thank you very much for the question, Bu Sari. I already mentioned in my presentation that actually accessing internet does not link with the improving woman knowledge on maternal health. Even though realizing that condition, I realized and we realized that internet or such kind of media have a very high potential to spread the good idea, especially for maternal health, because based on the last ITU index that Indonesia also have a high internet penetration user, and also we realized that Indonesia belong to one very noisy country in terms of using Twitter or social media application or something like that. And also based on this current reality during pandemic era, we should have less contact with other people. So digitalized era come faster than our expectation. Because of this potential, I believe that using this media will have a high achievement to spread the idea of maternal health. And about the question, another question which you write in the chat box, what kind of information that should be delivered for improving maternal health, because maternal mortality is preventable event, and it will be better if we focus on the prevention rather than how to cure the problem. Because of that, then BKKBN can focus on the not only postnatal, but many health treatment during the pregnancy. Back to the Indonesian demographic survey, if we analyze the data, there are some important aspect of health treatment during pregnancy which is still have least attention, especially for the woman. We know that containing protein in the urine have a high aspect or a harmful aspect when when the woman deliver. So check the urine protein, the protein in the urine should become one important aspect and your concern, because it is one of the least aspect that get attention. I think it's related to eclampsia, proeclampsia, or something like that. We can understand that many aspects only relate to the quantity. For example, the visit of posyandu or puskesmas, but the content of the health checkup still not have get much attention. I mean, we only focus on the utilize the health facility, but we do not focus on the quality of the health treatment during pregnancy or delivery, or also the postnatal. And again, this is not this is just my own experience, and also my previous long ago result of my research, that come or attending the health facility is not always in line with obtaining adequate treatment. Why? Because when we come to the health facility, there are so many complicated health systems that should be done before we get the treatment. Maybe Bu Ariane Utomo, who live in Australia, are really lucky, because I have also had experience in there, that we come to the hospital, even they didn't ask me, they didn't ask us whether you can pay the treatment or not, or you do have not, you have a guarantee or not to get the treatment. They directly give you a treatment, and all of the bill will come to our house. It's different in Indonesia. Even I have some discussion with village midwife. When they give their apa ya, they go to the reference hospital because they have our private practice at home, and they realize that they cannot handle the problem, and they bring the patient to the bigger hospital. When they go to the hospital, so many procedures, so many questions, so many paperwork should be done first before the patient get the treatment. And the other thing that also important is the patient. In my research, I suggest that we should educate the woman or the patient itself. When we go to the hospital, again, we go to health qualified health facility. It doesn't mean we get the qualified treatment, because in my opinion, we can argue in a positive thing with the health personnel, with the for example, the paramedic or the doctor or the pharmacy, something like that. We can ask the what is the medicine, what is the impact of the medicine, why you give me such a treatment like that, what is the best treatment that can I get for solve the problem. And unfortunately, such a good discussion is not a common in Indonesia. When we go to the hospital, it seems to me that we have a social distance between the community and the health personnel. The health personnel often put themselves upper than the community, so they are not. They cannot be not debate. Actually, they cannot be asked more explanation about what they done to us, even though we realize that their treatment have a big impact for our body, our health, our why I choose this. Actually, I'm statistician. I'm not much interested with this aspect, but my own experience when I go to the hospital, and it happened. The doctor asked me to abort my kid, and I get 3, 4, and three or 4 second opinion, and all of the health personnel get the different opinion, because based on the statistic aspect, I realized that diagnosis is also building a model. When you get the most information, so you will get a model, so the model will have a very precise to estimate the parameter, and the communication between the patient and the health personnel will build the better the better diagnosis for the patient. I'm sorry, maybe it's a bit misleading, but I try to answer what Pak Salut Muhyiddin write in the chat box. What is the impact of the or the role of institution? So in here,
sorry, Pak Teguh, I would like to kind of spread the time equally between the presenters. So maybe just very brief question to Pak Salut's question. Thank you. Very brief answer. Thank you.
That's all right. Okay, thank you very much. That's all.
Maksud saya silahkan jawab yang Pak Salut tapi briefly. Thank you.
Okay, yeah, I just want to say that is the importance of institution to support the maternal health, including the health facility, the family, and etc. So I just want to emphasize in here that availability of health facility is not always guarantee the quality of the treatment for the mother. Thank you. Sorry.
Nggak apa-apa Pak Teguh, justru harusnya kita bisa seharian ini child and maternal health session maybe sponsored by Pak Salut and our colleagues at Macquarie. It'll be a really interesting one. So the next question is for Ibu Dian from Pak Salut. Pak Salut, would you like to ask the question directly or would you like me to read it out? I'm not really sure. Yeah.
Is it possible to hear?
Yes, silakan Pak Salut. Mungkin pertanyaan yang untuk Ibu Dian ya.
Yeah, this is my first time to use WOFA, so I'm not so sure whether it's get through or not. But first of all, congratulations to everyone. It's really impressive. Specific question to Ibu Dian. I just wondered, it's really kind of like very impressive study, I will say, with rapid review. But just wondering if you want to go beyond than that one to make it like comparative analysis with others, but rather than just focus on calor itself, but also I know in Aboriginal studies, it's also they use different remedies, traditional remedies for breastfeeding, and then in Thailand as well in Africa. So putting that as a broader context, you may be able to put that into international journal. I don't know. That's kind of like encouragement. Thank you.
Thank you, Pak Salut. How are you, Pak Salut? Actually, the herbal, yes, there are so many kind of vegetable that can be used for increasing the milk production, like daun kelor or torbangun or milk or oat milk or red raspberry leaf or marshmallow root. And I will try to write more studies about that. Thank you for your support, Pak Salut.
Thank you. So next question is from Mbak Maria. Mbak Maria, would you like to ask the question directly to Sophia?
Yes, please, Mbak. Thank you so much, Mbak Ririn. It's nice to see you, Mbak Ririn. Prof. Budi is my promoter when I took my PhD. Thank you so much. So it's happy to see you. Mbak Sophia, that's a good presentation. So what is next? What is your recommendation for BKKBN? Because BKKBN nowadays have a new task to deal with the stunting. What is your recommendation? And then what is the target of your recommendation? And the second one, based on your results, what is the brief result that we can take as the message for the massive campaign on reducing of stunting? Thank you, Mbak Arin and also Mbak Sophia.
Yes, Sophia.
Thank you, Ibu Maria, for the question. The recommendation for based on my study is, in my opinion, that BKKBN can boost the campaign of birth spacing. I actually have did a little research about what have been done by BKKBN about the birth spacing, and I found several news that in several village the birth spacing campaign have already been done in there, but my expectation and my hope is that bird spacing campaign is the popularity of the longer bird spacing in Indonesia, or maybe the specifically is the healthy bird spacing, because from what I study, the very long bird spacing is also not very good for mother's health. So my hope is that bird spacing campaign will be as popular as contraceptive use, just like dua anak cukup, something like that. From what I know until now, that BKKBN have aware of the longer bird spacing, but the campaign it's still not widespread yet to the society and to the mothers in specific for specific target. For the target audience is the BKKBN for the supply side that they can bring the information to the mothers and Indonesian citizen, and also that information can be and also mothers, because they are the main target for the information. And for main result in my study, that is I found that the 3 to 7 years space between 2 consecutive births have been proven that it could reduce stunting probability by 36%. And my study actually in line with previous study by Dewey and Cohen at 2009, if I'm not mistaken. It is said that in the country where birth spacing, where the birth spacing is significantly affects stunting, then the prevention of then the intervention related to birth spacing will lead to stunting prevention from 10 to 50%. So I think that effort is worth to try. I think that's all. Thank you.
Thank you so much. So we have 4 minutes left. So thank you so much for everybody. In the 4 minutes, what I would like to do is to invite all the presenter, Pak Teguh, Mbak Dian, and Sophia to turn on their camera. And if you don't mind, if you could just say a couple of words about what you have learned from the other presenters' paper this morning. So just a quick reflection. So maybe I will start with Pak Teguh. Are you still with us, Pak Teguh? Yes, silakan Pak Teguh. So a couple of words on your comments or what you've learned from Mbak Dian and Mbak Sophia's presentation. Silakan Pak Teguh.
Okay, baik, it's great to know a different kind of aspect of maternal health. In here, I learned much about something traditional but useful to improve the maternal health, and it's good for me and will enrich my knowledge and widen my spectrum to understand maternal health in more detail. Thank you.
Ya, terima kasih sekali Pak Teguh. Okay, next Mbak Dian, what have you learned from Pak Teguh's and Sophia's paper this morning? Silakan.
Thank you, Ibu Ririn. It's very interesting because now BKKBN is dealing with stunting and maternal death as well. So those presentation is very useful for our institution as well. So thank you very much for the insight, and I will give some information future for my boss in BKKBN. Thank you.
Oh, thank you so much. Last but not least, Sophia, what have you learned from Pak Teguh's and Dian's, Ibu Dian's presentation?
Okay, it is so interesting to learn from the professionals, which is Bu Dian and Pak Teguh. And I hope that my study can contribute a little with the real and bring a real impact with maternal and child health in Indonesia. Thank you.
Thank you so much. So that's all I think we have time today. It's so unfortunate that the pandemic has gone on for such a long time, but given the very difficult situation and the challenges that Indonesia is facing at the moment, I would like to say thank you, terima kasih banget to Pak Teguh, to Sophia, to Dian, to all the audience in the room who has come and listened to the presentation today. Thank you so, very much, to Mbak Ratri for hosting this particular session. Usually in a traditional conference, what would happen after this session is we would gather around drinking tea or coffee, maybe makan lemper risoles, dan mungkin Pak Teguh and Mbak Susi, Mbak Sofia, Mbak Maria bisa bertukar kartu, right? And follow up. What are the next step collaboration between researchers and institutions to kind of address challenges with child and maternal health in Indonesia. Unfortunately, we may not be able to do that, but don't let that stop us from connecting and collaborating. So I'm pretty sure the WOFA app initiated by IRSA has been quite useful, where you could find the contact details of all the participants. Waktunya sudah habis, menarik sekali. Saya belajar banyak banget, pengen main ke kantor BPS yang di depan Pasar Baru, atau jalan-jalan juga ke BKKBN dan juga ke Jogja. So thank you so much, everybody. I look forward to see you in another session in the conference.